Thanks, Ray. We've heard some really terrific talks in this session and examples of how multidisciplinary care can or should be integrated within our usual care for patients with IBD. And over the next 10 minutes, I'm going to share with you some things that we've done at our institution, some of the rewards that we've appreciated, and some of the challenges as we've gone to try to practically implement many of the ideas that have been discussed. Really, inflammatory bowel disease needs no introduction as to why. Recognizing that this is a complex illness that affects people at various stages in life makes it really a ripe environment to consider multidisciplinary care and may be different than many other diseases as we explore various different kinds of innovative healthcare delivery models across the medicine spectrum. In the U.S., our efforts to describe and define quality measures and quality metrics have largely focused on processes of care and outcomes of care, things that we do or what happens to patients as a result of the care that they receive. However, I want to point out this paper from Spain that looked at what is really defining high-quality care at an IBD unit in Spain, and where they actually focused largely on the structure of care, which is something that we haven't really thought a lot about when we think about quality improvement. What is the structure of the care in which that quality of care is being delivered? And highlights from the Spanish initiative to define high quality care focused on multidisciplinary care teams. And it's not what we do, it's really the structure in which we work, and it takes a very different approach to improving the care when we actually focus on the structure. The structure of care might be building a new hospital, nursing to patient ratios, or it may be the accessibility and availability of a multidisciplinary care team and being able to provide care across the continuum, similar to what we've just heard. I think there's many different ways that we can think about improving the structure of care from the very traditional one patient, one physician, or one patient, one provider, and then the patient goes out sort of and does everything else that's outside of the confines of what we see when we're directly with the patient. We'll talk now about multidisciplinary visits that we've tried to pilot at our institution and that we've heard some examples about, specifically related to surgery, and we heard a little bit about surgery earlier, antepartum and pregnancy clinics, as well as integration of psychosocial and nutrition services. Also, I want to touch on the concept of a group health visit as another innovative care delivery model that uses a multidisciplinary approach. What we won't have time for is to get into other structure of care changes that can improve the quality of care related to telemedicine and care pathways. So thinking about nutrition, psychosocial care, pregnancy, and surgery. So we talk about our current practice. Patient's all excited to come see the physician. Physician has an interaction with the patient and says, you know what, by the way, I think you need to go see my colleague who's a surgeon or an OBGYN because of this particular issue that you're having. I'm recommending this, this, and this, and maybe it'll be buried in my note, but tell that physician if they think anything differently, please to pick up the phone and give me a call. I'm happy to have a conversation with them. So the patient goes to see the provider, maybe they'll make the appointment, sometimes they don't, as we all know, and they're going to have a great interaction with that provider, and that provider is going to make the recommendations that they make, and they tell the patient, well, you know, if your gastroenterologist has any questions, please just tell them to pick up the phone and give me a call, and I'll be happy to address any questions. And we know how that goes, and we heard earlier about the really critical importance of communication. And when we're not directly there with the patient and the other provider, there's certainly room for that communication to break down. So the concept, as Amy put it, this is really an ideal concept, is to create a one-stop shopping approach for the patient. Wouldn't it be great if we could bring everybody together with the patient in the room, together all giving the same message or complementary messages that the patient hears consistently. We know the patient's actually seeing the other provider and getting the message that they want. And so we'll talk about how we've done this in a few different programs. So when we set out at our institution to develop these multidisciplinary care clinics, really involved in a basic assessment of need. It wasn't just a, let's go out and do this. Let's really understand what it is that we're trying to do. Establishing buy-in from all the stakeholders is absolutely critical. Who is being touched by this change in the process of how we do things and this change in the structure of how we do things, all the way from the assistants who answer the phone and make schedules, all the computer people who set up our scheduling templates, figuring out the room allocation, understanding the reimbursement issues and the financial stability of these kinds of, introducing these kinds of programs are not simple or straightforward. I work at an academic medical center, but at a large community practice, these are all considerations also that need to take place. Engaging the leadership is absolutely critical. To start a program, a multidisciplinary program, you really need buy-in, not just from the colleagues, not just from the stakeholders, but from the very top in order to make sure that it gets executed accordingly. We developed a business plan, and a business plan is really important because multidisciplinary care, there's no easy way to make sure that it all gets paid for through our usual reimbursement processes with third-party payers. And so developing a business plan, trying to understand what is the financial impact to my institution, to my program, to my practice by instituting various kinds of multidisciplinary programs. And that financial impact may also come in the form of it's good for business to be able to provide this kind of care for patients, and word may spread and could be a marketing opportunity. Establishing metrics for success is important to understand, are you actually making a difference? And then all that goes into consideration before the actual launch. Many challenges go into developing a multidisciplinary care program because you're trying to juggle multiple providers, multiple specialists, making sure that you're coordinating appropriately people's schedules, getting approval from the right people in the right departments, making sure that whatever equipment might need to be available is available, and again, thinking about the finances and the ultimate coordination of care. So we decided we want to implement a multidisciplinary nutrition program, recognizing, as we all do, that this is a significant need in IBD, and also recognizing it's a non-reimbursed service. Lots of clinical issues. We wanted to train a nutritionist ourselves, not just somebody with a nutrition background, but to recognize what are the specific issues in IBD related to both malnutrition as well as related to diet and how it may impact the disease. When and how should a nutritionist be introduced? There's many models out there. The pediatric model, where a nutritionist is available to see patients as they come in. The PRN model, where a nutritionist might be referred patients as needed, or screening for high risk, and we kind of tried to incorporate all of these. We heard earlier about different surgical programs. We have a J-Pouch program, which is modeled after the Cleveland Clinic. I picked up the phone to Bo Shen. I said, Bo, how do you guys run your program? And we tried to model ourselves after that. You really need an able and willing surgeon to work with. But we created a J-Pouch program once a month where Phil Fleschner, who's a surgeon at this meeting, you'll be hearing from him later on in the meeting, and I together have time where we scope patients together, and then we see patients for consultation together. A referral process had to be created. It's really difficult to coordinate and align schedules, but it can be done. And recognizing that the financial sustainability also comes along with rules and regulations that may be local, but they need to be considered because most plans will not allow billing to occur from two physicians at the same time. For pregnancy and fertility, we created a program that's modeled after the IBD Mom Clinic that occurs in Shaare Zedek in Jerusalem. Ariella Shitrit is the pioneer of that program over there, and there's other examples of pregnancy and fertility practices. This used a slightly different financial model with a staggered billing approach, where one of our IBD providers goes to the OBGYN department, sees patients over there right before or right after an OBGYN visit. So there's an opportunity in rooms right next to each other for the patient to hear from both the OBGYN as well as from the gastroenterologist. We developed a psychosocial program with an embedded social worker and an embedded psychiatrist within our program. And again, this is a non-reimbursed service, and for this service we had to fundraise. We had to raise money for the social worker's salary. And actually, this is something that we found that grateful patients are willing to support because this is a program that tends to speak to many people with IBD, as we've learned this afternoon. Our social worker has actually been critical to help to identify patients who have specific needs. We have a screening process where all patients fill out questionnaires before they get seen by the provider, and the social worker then steps in to determine what those specific needs of the patient might be. And then to talk briefly about group health visits. This is a concept that we took from a diabetes program at a local Kaiser in California. And what they do is they have one provider who sees multiple patients at the same time in a large room and providing care to all of those patients. And this is specific to health maintenance issues. And so we've run these group health visits using the help of an advanced practice nurse. Again, another example of multidisciplinary care where patients receive didactic education all together at the same time. We offer on-site vaccinations. Patients fill out a pre-programmed questionnaire for targeted quote-unquote therapy related to their health maintenance, so they have a customized report of what healthcare maintenance needs they are, and then those needs are provided for or referred for at that particular program. So putting it all together, a one-stop shopping approach is complex to organize, but it is feasible, but it may relate to the specific issues in one's particular practice setting. It can improve adherence and compliance with specialist referrals. Patients can get consistent messages, and patient convenience is significant, which can boost patient satisfaction. However, these programs are difficult and complex, and there's a lot of financial considerations that need to go into understanding the financial impact of developing and creating such a program. Ultimately, our goal is to provide high-quality, multidisciplinary, comprehensive care. This is one example of how we've been doing it at our institution, and my colleague Miguel Reguera will share a very different example about how they're doing it in Pittsburgh. Thank you very much.
Well, thank you very much. So just to start, we know we're running late. We're still going to have a 30-minute break, and we're going to forego the panel session, but I'll let Ray and Susie end in a second. So in the next 9 or 10 minutes, I'd like to just discuss a new model of care that we've developed in Pittsburgh, and it's a specialty medical home. Some of you have asked, is this possible in your own groups, your private practices? And I've actually been working with some groups around the country, even in the community care setting, possibly looking at some of these new models of care. So what is IBD Medical Home and a specialty medical home? So in essence, this is taking a patient and putting them at the center of the universe, in which there are nurse practitioners, surgeons, a multidisciplinary team around, much of which you heard today. In the bottom right corner of this, and what I think is very important, and Pam Levy and Randy Siegel from our center are here, are the peer specialists and having patient advocates that are part of this and help design this from a patient standpoint. Also for us, what we've done is we link to an insurance company, our own UPMC health plan. Many say, well, if you don't have your own integrated health delivery network system, is this possible? And the answer is yes. And the insurance companies are now looking at population-based health and working with multidisciplinary groups to look at not only improving outcome, but potentially decreasing cost. So what do I think is necessary for a specialty medical home? And this isn't just true of IBD. This could be multiple sclerosis, RA, and a number of other diseases. Well, one is that the population is primarily seeing you, the specialist, for their disease. So Crohn's and ulcerative colitis, and a gastroenterologist. I do think that there needs to be some relationship with an insurance company or health plan, as many of these models are a payer-provider mix. How this will evolve over the next several years still remains to be seen. Obviously, you've heard today, and the key theme in terms of any chronic care model is team. Team of physicians, team of healthcare providers, and others. So what we did, and I'll just very briefly show you some examples from our practice, is we aligned with our UPMC health plan insurance company. We looked at patients who had Crohn's and ulcerative colitis, and their primary disease and chronic disease model was driven by their IBD. So us, the gastroenterologist, felt that we could serve as their principal care provider. And this was really built on the back of an IBD traditional medical center. So for those of you in academic centers or large private practices that work in an ACO model, this is working with an integrated group of healthcare providers to then align the medical home. Out of that, we carved a group of people that were interested in this model. So Eva Sigathy is my co-director in this. And in the red letters, and I won't read down all of this, these are positions that are actually paid for by the insurance company. So the health plan is now aligning with groups, not only ours, but others, to look at these specialty models, and actually, rather than writing a grant or going to a generous donor, there are actually health insurance companies who are interested in this. So how does this look? And I think some of this is the high touch. So in the big groups that are used to using central scheduling, I think that that's a catastrophe, and that's the most anti-patient-centered mode. I get in trouble when I say that in my own hospital because this is the new way that executives like to deliver healthcare delivery. But having a real person on the phone who's embedded in your center, for us, has been a key portion of this. We actually train our schedulers from the start to ask patients certain questions. And I think Corey said this earlier, and this is a key concept. We should ask our patients, what are the top 3 things that are bothering them? What are their problems? And what are the top 3 things that they want out of their visit? And it's very interesting, and I'll show you this example, and this will be handwriting that I'll read, of one of our patients. And see that this is a 34-year-old with severe Crohn's who's on biologics, and the question is, how much of that drives her questions in terms of the problem and what she wants out of the visit? So number 1, public transportation in Pittsburgh sucks. Number 2, I'm stressed out of my mind. And number 3 I have pain in my bones. These are her top 3 problems. The combination of biologics and trough levels, and like Corey said, become a little bit less. What does she want to get out of the visit? She wants more energy. She wants Eva Sigathy to design a designer drug called Chilaxin, and she wants a massage. Now, we all laugh, but if we don't ask our patients what they really want, we will never know what drives their interest in the visit. And some of this actually informs us in how we may design future multidisciplinary care. We do meet as a team. We huddle before the visit. We do have different rooms, and this is a kind of a low-tech view of our clinic, and this is up to now 5 or 6 rooms where the red boxes equate to each of our clinic rooms, and we'll slot the surgeon, psychiatrist, dietitian, social worker, and we'll have this integrated and multidisciplinary approach. Now, as a gastroenterologist sitting there and thinking already, how can I see this many patients in a day? Well, some of these patients I may, as a gastroenterologist, spend 3 or 4 minutes on because their primary driver isn't their GI disease, but maybe it's psychosocial, maybe it's diet and nutrition. And the after visit often doesn't require them coming back to the hospital, but some of this we can do by phone or by telemedicine. So this is Eva doing a telepsychiatry, and now she's doing every other visit in a telemedicine format. This is actually very effective because the patients hate coming to see us in the city. They'd rather stay at their home and in the communities, and I think leveraging this technology is important. And then finally, we do meet regularly to discuss the patients, and especially those patients that may be utilizing care in a higher level. So I'm going to end with some of the metrics, but then just a final example of a patient, and then we'll probably end this session. So this is our 2-year update. We've enrolled 552 patients. We're actually now up to about 600 patients, and you can see the new and return visits each month. So this is an active enrollment process. We do look, this is Pennsylvania. We have focused more on the western part of the state, but we are starting to move across the state. And as we look at population-based health, there may be ways to capture more regions with working with practices and community physicians in a way that I think we haven't really realized the potential behind this in the future. We have shown a decrease in utilization. Let me make no assumption. If the health plan and insurance companies involved in this, they're going to want to see decreased costs. So decreased costs can come in different ways, but unplanned care by decreasing emergency room, by decreasing hospitalization, and obviously we had a number of other metrics such as quality of life pre and post that we were interested in. And I think leveraging technology, and now Sandy Kim is in terms of pediatric, looking at whole life care from birth to death is going to be critical for these populations. So here's an example that I'll end with of another patient who's 1 month into her medical home. This is a 44-year-old male with Crohn's. He's had multiple surgeries. He has no active disease on adalimumab. Let me say that again. He has symptoms, but when you do testing, you don't see disease. How many times do you see these patients in the hospital in your office? A lot of times I bet we cringe because you know this is not going to be an easy visit where we need to manipulate the biologics, yet he comes in over and over. This is his epic screenshot. He had 14 visits to the ER in a 6-week period prior to the medical home. So he's going to the ER, And what happens when he goes to the ER, and I think multiple other people have said this is his epic screenshot of his radiology. Well, we've well radiated him. He's had a lot of radiation exposure, and if that was a treatment for IBD, I think we've done a pretty good job. How many of these CT scans has he had that's changed his outcome? 0. What else have we done then? We flipped the model. Now, you may cringe looking at my name on the right-hand side and how many dates close together, sometimes twice in 1 week. But remember, in these team-based multidisciplinary medical home models, it may not be you as the gastroenterologist that's central to the care, but rather the team. So for this individual, he actually started to see us twice a week, once a week. We do telemedicine with him. And by having that engagement and that activation, he's now part of his care pathway. So I'll just end with us and ask the question, are we ready for specialty medical homes? And I think the answer is we may not be in terms of our culture and the way we have trained as specialists, but we better be as terms of the way we were interfacing with our payers and our insurance companies. Because if we don't figure out some of these chronic care models that we as specialists take hold of, we will be told at some point how to do this. So thank you very much for your attention, and I appreciate the time.